between micronutrients, vitamins mostly in this case, and trace elements, two groups. And the learning objectives that we have is how to become aware about micronutrient potential deficits or even severe deficits in acute illness, and of some difficulties associated with acute illness in evaluation of micronutrients. A few words about reasons for low blood levels in acute illness. This is an important point to consider. And the difficulty of monitoring in the active phase of acute illness. I will address a little bit again refeeding syndrome. You have heard already from Karin about the thiamine supplementation, so this will not be new to you. And there are a few specific conditions where efficiency of providing routine vitamins or cocktails has been proven efficient, and I will address a few of them. And so I will not go in all these data, but what is in blue is part of the presentation of today. Previously, we had a question about contamination. But this is in some way not an appropriate concept. On this cartoon, you see the deficiencies that are distributed in different countries. Some are wealthy, like the UK, some are less wealthy, some are enormous countries in the world. The largest country in the world is India, and you see on the top, and this is a very recent publication on the deficiency of vitamins and micronutrients in preschool children. So 56% worldwide have deficiencies. You heard about the anemia problem just before, but iron is in red, and you see that it's not only iron. In some countries it's zinc, in other countries it's folate, and in gray he illustrates when there is more than one deficiency in this country. And at the bottom you see the same spectrum of deficit in non-pregnant women. And what explains some of these differences between the countries? It's first the water on which plants are growing. And there is a very famous study where there was then a side effect of supplementation of selenium, because in one part of the world selenium is in the soil, and it was a high level was present already, and putting something on a high level was not very smart. And this is the redox trial, yeah, where that are naming. So based on what environment you are living in, first from the water and how the plants grow in your environment. If you are only importing your food, then it might relate to the countries where the food is imported from. So it has something to do with the food industry. And then it has to do with the diet. We had so nice slides from Karin about in which products you find I would say the trace elements, but also some vitamins that are contained in this. The vitamins are more or less in the nutrients that you are eating. The small elements, zinc, copper, are in the water, and in the water that is feeding the plants do not have the same content in all regions of the world. And this explains all this variability that you have to account for. I'm insisting in not confusing contamination. It's also the background of life that is the basis of it. And there is another important point, and this is now for the acutely ill. The acutely ill distribute into two groups. One group is the acute illness based on a trauma. It is health and illness. But about half of the patients that are going in an acute illness have a history of being already ill before. They have chronic illnesses, they bring comorbidities. And some have been addressed: chronic renal failure, chronic heart failure, intestinal absorption problems are all contributing to a risk profile that is present when you enter. And this cartoon shows the risk factor for, it is from the paper. You find it in the micronutrient LLL related paper, because you find then that there are a few conditions: acute kidney injury, chronic renal replacement therapy, heart failure, trauma, refeeding intestinal failure, and I put with a question mark viral infection, because apparently not all viruses elicit the same reaction. There is a lot around COVID, but it's also very heterogeneous. Again, this background, where happened the COVID, and it might be different, a European COVID or a Chinese COVID, in regard of, again, the water on which the people are living. So, and in the first column there is the association with disease. So there are, it's maybe the kidney, the heart, refeeding syndrome, and I put also viral infections. Malnutrition on admission is quite rare, and there is a certain development when it's not a chronic disease. If there are biological fluid losses, that's frequent with renal replacement, that's frequent with trauma, because you have extensive wounds where there is something running out, and you may find it also, of course, in major burns and intestinal failure with fistula. So you have to consider all this mixture of elements that is increasing or decreasing the risk. And now I would like to shortly address the problem of inflammation. So the part of the patients that are previously healthy, let's say coming with a trauma or an acute pneumonia or an acute infection as it was associated with COVID, they may have a normal status in their micronutrients and before they come. And then if you measure the micronutrients, you have seen one slide that I will now repeat here. And this slide shows that on the x-axis you have increasing level of CRP as one easy measurement of the inflammatory status, and on the y-axis you have the presence of vitamin. And you see, okay, with very high there is a decreasing level of zinc, there is a clear decrease of selenium, there is not much in vitamin E, surprisingly. There is again the highest inflammation, vitamin B is disappearing, but there is a kind, what is this inflammation related to also? So, and the background that they are bringing. In copper it's the reverse, it tends to be high with inflammation. That means that potentially the copper utilization processes are stopped or are reduced in this, or that the turnover of copper within the body is higher, because if you have a high turnover of a certain element, and this might be autoregulation, the level might be high, but it might be the kind of protective element that is happening at this moment. And in vitamin B6, one that we have addressed with the refeeding syndrome, and in vitamin C there is a clear disappearance. But this disappearance of certain elements associated with inflammation, it could also in inflammation be a sensible reaction of the body. What is not on this cartoon is iron. Because in acute illness, iron virtually disappears. And it disappears because the body has learned over millions of years that the bacteria like iron. And if you feed with iron the bacteria that are circulating in the blood, they are proliferating. And that means that low iron in a patient that is acutely inflamed in the ICU may not be a super approach to this. And this has been tested in a randomized trial where it was not successful to improve outcome that we will not address. And one point that I would like to remind, it comes later, that blood sampling is a big issue of making things disappear out of the body. And typically it has been shown that for 10 days of ICUs, it is 1 unit of blood that has been taken. So after some time you have a blood sampling induced anemia. But if you give 1 unit of blood, your iron stores are full for the next, because there is a breakdown of some of these erythrocytes that are external erythrocytes. Your iron stores are filled up for the next weeks. Yeah? So if you have given blood, then probably your iron is okay. This is an excursion into the world of iron. So now you know it's what this cartoon also shows, that the confidence intervals are very large around these changes. That means that they can be individually different, and that there is no formula that tells you if the CRP is 20, your vitamin C is allowed to be 10 or something. No, you cannot calculate. It's just a general trend that the body is reacting, and it is reacting also in the management of the internal micronutrients that are available in the body. And this is a nice cartoon that I like, because it shows this hierarchy that there are clinical outcomes are related if you have a real insufficiency. This is the bottom of the pyramid. On the top of the pyramid you may have altered serum value, but only if it is associated with a severe deficiency. At the bottom you have, then first you have physiological, then it might be related to redistribution. It might be a physiological adaptation, as I have alluded to, with associated with inflammation. And below that, on the ground of the insufficiency, is this pyramid that is built up. And so the history, the place where you live, the place what diet you are following are all contributing to the situation that we are facing, and that it's not easy. You have heard that not all measurements are super good measurements and they do not reflect what's there in the cells. So selenium has been tried out in sepsis, no clear signal that in the ICU it is promoting a better outcome. Yeah? So this is for the moment over. Vitamin C has been tried. In this trial, 12 to 16 grams. You see on the right hand side that if anything, vitamin C is a little bit worse than the other, but I would say the two lines are quite parallel in general. So it did not help. This is an interesting study, and it was quoted before that it could be show some effect. In this study, they replaced quite nicely. So most patients with the replacement that has been taking place, 50 milligrams per kilogram every 6 hours for 4 days. They were successful in putting the patients in let's say, above the threshold that is illustrated by this dashed line. But there was no effect whatsoever on the inflammation, despite the fact that intensivists are very strong believers on the story of the reactive oxygen species, and that vitamin C is fighting against. In this trial, it did not work at all. There was a funny thing in this trial, that they found that the mortality in the first day of application is different. The difference is only, if you look on this cartoon, on day 1, because then the curves are parallel. This is a little bit mysterious. And this is 1 out of 43 secondary outcomes, and it was not powered for this. This is probably an artifact of a sample that is studied. And it should not be told that there was a survival benefit based on this data. Because all other studies, again, vitamin C in COVID, you see the mortality is higher than small higher in vitamin C. So all systematic randomized trial with high doses showed rather some risk. So the idea is probably they also were longer on organ support. That's shown on the right hand side with these red bars. Vitamin C has a little bit more red than the controls. Vitamin D levels are low in sepsis. So clearly the signal is if you have sepsis, vitamin D is low. Vitamin D has been supplemented. One famous trial has been done by Karin, and she found in a secondary analysis a signal in those below 12 nanograms, but not in the overall intention to treat. Is this correct how I tell it? I have to try to be very careful about this kind of thing. Yeah, but there is a kind of hypothesis, other ways of supplementation, different doses, different populations, and this might be a reason of the heterogeneity in this meta-analysis. So, as a summary, in acute care there is no clear signal for any of the high-dose supplementations of any of these elements. So, please just supply with the normal dose that is recommended daily allowance. We do not know much at the moment whether it should be 2 or half a recommended daily allowance. I at least do not know, and I am not so sure whether others know it really. Yeah, what about this refeeding syndrome? The refeeding syndrome in acute care needs to be a little bit expanded, because the refeeding syndrome in acute care happens even if you are not feeding the patient. Because in acute illness, patients are fed from inside, because they come from the breakdown of the tissues that are producing glucose. And this is also a kind of feeding to the body. And if the body comes depleted, it may also initiate hypophosphatemia or the reaction of low associated with low thiamine. So in general, it has been found that there is a proportion of 17 to 52% of ICU patients that around the time where you start nutrition, but this is also timing in the ICU, it's related to the length of stay here, but many have found that there is a fall in phosphate, that in approximately a third of those is so profound that we think at the moment that it's a compromise to, or it's increasing risk for the heart, for the metabolic production of ATP. There is also one field that is important, and that's oncology. It has been shown that in oncology patients, where the treatment makes also transitions from a blocked metabolism to a started metabolism, that it's up to 80% that experience refeeding syndrome, based on measuring low phosphate, I must admit. Yeah, and we are here. So this is the cartoon. If you refeed, then glucose and amino acids go into the cell, and they take with them phosphate and thiamine, and then there is not enough around. And then the insulin pushes also the potassium into low potassium. Is also part of this refeeding syndrome story. That should be corrected, and it could result in this amount of symptoms that is like a chameleon of being in poor conditions. You can have myopathy, you can have arrhythmia, you can have heart failure. I'll show you an example in a minute. You can have ileus and gastrointestinal dysfunction associated with a refeeding syndrome. You can have delirium, and the delirium can be so extreme that you can go into a Korsakoff-like syndrome. So refeeding is dangerous. And there is also an increased glucose intolerance. You have heard that vitamin D is interesting related to glucose. And it's also in the refeeding syndrome, so we have to be a little bit careful. And you can have a mixture of symptoms that are very unspecific at the end, because it's just illness. I put here because there is so much uncertainty, how can you replete? There is a simple way, go for 10 mill. If there is an acute hypophosphatemia, you go to 10 millimole per hour, you can calculate it here, but after 3 to 6 hours it's enough. Because typically after roughly 30 millimoles, it might be repleted, but you don't know exactly, because the intracellular you don't know. So go fast, but then measure. And you can see here that in moderate or severe hypophosphatemia, it succeeded to bring most patients in the correct area, but it do not continue too long. And this formula is rather reasonable formula to determine an estimate of the missing values. Of course, hypophosphatemia and refeeding syndrome, there are recommendations that are written in the ICU guidelines that you go down with the energy of the nutrients, so you go lower to about a quarter. Nobody knows exactly whether it's a quarter or half, but don't escalate nutrition and rather go a little bit conservative, less calories, and then progressively you go up. In the meantime, you have replaced your electrolytes. In the case of refeeding syndrome, electrolytes are super important as well. This is the case that you can study. It's you see a normal ECG, and without much knowledge, you know there is an enormous heart here. Yeah, you do not need to be an intensivist to identify it. There is a sinus written. There is a history of eating only white rice by this guy. Yeah, and apparently alcohol also. You see in the top cartoons, you see look at this part here. This is the left ventricle. And it is large. And if you look here, the left ventricle after 6 months after repletion is small. And here you see that there is a mitral insufficiency that is dramatic, because the heart is dilated and so the valve is, and this is completely away after repletion of thiamine. So heart failure, unclear heart failure, mandates that you give thiamine, because if it does not help, at least the side effects are little, but you may reverse acute shock. Cardiac shock may be related to thiamine deficiency. And this shows that in any case you can try in patients with and without renal replacement therapy, and it's 100 to 300 milligrams for 3 to 5 days, then usually you are full. The normal daily requirement in LDA is 1.5. So this is really a big dose. In some kind of, so what around the cardiac function? And I would like to insist that some of these micronutrients are key for energy production. That's why the thiamine is so important. It's related to how much ATP you are producing out of your nutrients. And this is also a role that we can see together with vitamin and selenium in the function of the heart. And there are nice trials that have been done in patients with heart failure, where you got a micronutrient cocktail, and your left ventricular ejection fraction increased slightly, and the volume of the left ventricle decreased slightly, what is a very good sign in patients with chronic heart failure. 10% decrease in volume is a massive improvement. That means just dyspnea or no dyspnea in these patients. So, and it has also been shown that vitamin C is helpful. So they have probably a chronic deficit and it helps. So there are conditions where it's not a real acute condition, but heart failure and dyspnea is an acute condition if you have pulmonary edema. So in these patients, I would say thiamine, vitamin C, and probably increase the supplementation. There is an interesting field that is cardiac surgery, because this is a controlled injury and a controlled inflammation. They all go up to 200 to 300 with their CRP within 3 days. So who says this is not an injury? I go in a real infight with that. And what you see on this study from one of the members of this special interest group, that in patients that are in multiple organ failure, then you have lower selenium, zinc and copper than in patients that have no organ failure. So again, in more severe illness, but in cardiac surgery it's also associated. Longer surgery, more fluids given, more blood replacement. So there is a cocktail of risk factors that can be also related to the dilution and the higher inflammation and the larger trauma. And of course, then it is a predictor also of poor outcome. But it does not tell whether the supplementation in this case is super good. This has been tried here to supplement vitamin C levels. They are successfully increased, but nothing happened in the inflammation in this patient. And that's again supporting this idea that in certain conditions the body is hiding some of the micronutrients, and we do not exactly know always why the body does this. And here, supplementation has been tried. Selenium, high dose, it's a reasonable trial, 1,300 randomized patients, no difference in mortality in cardiac surgery. So, acute supplementation of selenium, no way. So, I think there is no evidence for it. Major supplementation in patients that have signs of heart failure, reconsider thiamine, vitamin D, and I think go a little bit more and think about it. Yeah, so heart failure associated with the cardiac surgery might be an area that needs to be investigated. Of course, related to renal replacement therapy, I'm coming soon to an end. This is the area where you are just withdrawing out of the body micronutrients. This has been shown by the chairperson of this micronutrient, LLL. She has identified that over the period it's a constant loss of micronutrients that are just going out of the body. And there is a kind, I would say at the moment, recommendation that you double the dose. But there is very heterogeneous. In half of the ICU this is not done. And we do not know why. Because there, I think it would be reasonable at least to double it. We do not know whether double is enough. But it's a reasonable approach, I would say, at the moment. And I would do it for micronutrients and the water-soluble vitamins, not for the fat-soluble because they are not filtered out. Yeah? So you might select another product than the usual product that they use for vitamin supplementation. So it's all very logic at the end. Micronutrients. So this is a kind of summary that shows that what happens in a cell depends on the therapies in the ICU, on the absence of being in, this is sun exposure, so it's vitamin D that you need. Then there is losses that are related to to the loss in the wounds. Then there is the pre-ICU, what the status that you bring with you and the world that you are living in. And then there are, of course, some disease-related things. So my key messages are, I think, very easy. In inflammation, the levels do not help you for decisions. Yeah? So you have a little bit to guess, and it would be good that you know whether in the population, the country where you live, it's typical to have deficits. Because if it's typical to have deficits in the country you live in, it's probably also good to supplement higher in illness than in areas where already the status is good. And that might not be an error of some treatment. It might be just the soil on which you are living. The treatments like CRT may be related, but also, for example, diuretics are a risk factor, because if you have a lot of urine, there is also a loss. So excessive diuretic or long-term high-dose therapies have associated risks related to micronutrients. I think it's not only the antioxidant defense that is important, it's also the participating in energy-producing process, and that's most important in acute illness, because at this moment you need energy, and you need energy in a physiological manner. And they work together. I think that's a nice message. Micronutrients, they are interacting, working together, and supplementing only one is really a very smart approach. Thank you very much for your time.
Thank you, Mikael. Is there a burning question for him? I think he's been very clear. We are not supporting single micronutrient high dose, which is called supplementation. We support repletion and complementation of nutritional doses. And that is the reasonable amounts. You will never hear us support those big stuff. So thank you for being here.
Great.
We will find those